If anybody does not want to join, that would be the time to do it. Okay, great. Well, we will go ahead and get started. Good morning, everyone. Lisa Letourneau with Maine DHHS, here with several of my colleagues from Maine CDC and DHHS, and we're hosting a special session of what has been our monthly clinician info session on COVID-19 vaccines, recognizing that there have been a whole lot of updates lately. So we appreciate your efforts to join us for this additional session. So with that, we have Director Shah with us. So I'm going to turn it to him and he'll kick us off.
Great. Well, good morning, everyone. And thank you so much, Lisa. And thank you all for taking some time out of your morning to join. As Lisa mentioned, we've got a number of our colleagues from across DHHS who are joining today to try to answer any questions that you've got and tee up issues that we might see coming on the horizon over the next couple of weeks. A few housekeeping notes before we dive in. As Lisa had maybe noted, or you may have already seen on your screen, this call is being recorded for possible future posting so that others may watch it and take advantage of it. If you have concerns about that, please disconnect now. This call is also off the record and not intended for any members of the media. If you are a member of the media, please disconnect now. If you're a member of the media and you have questions, please reach out to Robert Long or Lindsay Hammis at the Maine CDC with any questions that you might have. Finally, what I'd like to do today is to throw some slides on the screen and sort of move through them section by section. And at the end of each of those sections, take a minute, see if there are any really topical burning questions, answer those, move on to the next section, but ultimately try to leave as much time as we can for questions at the end, which is usually where we get the best dialogue. So with that, again, we are also joined by a number of other folks across DHHS. In addition to Dr. Letourneau, we have Dr. Stephen Sears, who many of you know. We have Director Bill Monteo from the Division of Licensing, Tanya Philbrick, who's the head of our immunization program, Sarah Gagny-Holmes, the Deputy Commissioner at DHHS. So among all of us, we hope we can at least try to provide some clarity on where things are right now based on your questions. So with that, I'm going to go ahead and dive in and make a hopefully successful attempt at putting these slides on the screen and get going off to the races. So here are among the topics we'd like to touch on today. First, just to provide an update of where things stand with the vaccine. Certainly within the last 24 hours, we've got the more recent news of FDA's full approval of the vaccine, the Pfizer vaccine that is. There's also been updates around dosing for the 2 mRNA vaccines, a set of recommendations for immune-compromised individuals, and then eventually, probably in mid to late September, recommendations forthcoming around booster doses for individuals. We'll also take a minute to touch on things like variants and how those have affected efficacy, as well as some context around breakthrough infections, as well as some recent changes that we've made around vaccination of healthcare workers. The principal focus for today and the intended audience for today's discussion is really around these clinical topics. Certainly there may be questions from a regulatory perspective around the healthcare worker rule. We've got the right folks to answer those, but we'd really like to focus more on some of the clinical issues that have come up recently. So with that, as folks are aware, we've got 3 vaccines that are currently on the market, 2 mRNA and 1 adenovirus vector, all 3 of which have been extensively studied at this point. The main difference from this slide that is recent is something we're going to talk about in a second, which is the FDA's most recent move to authorize, fully authorize, actually approve is the more technically correct term, fully approve the Pfizer-BioNTech vaccine for individuals greater than or above 16 years of age. I want to just draw your attention to that. For various regulatory reasons, for children aged 12 to 15, the vaccine is still authorized, but its administration is under the emergency use authorization provision. For the full biological license approval is just for those 16 and over. That doesn't really make any difference in practical terms. It's just something I wanted to flag because you may see it covered differently in the media, or you may even get questions about it from patients. And I wanted to just note that the full approval pertains to those 16 and over, but that doesn't really change anything. It's just that the data that they had going out were only those data for the 16 and over that met the criteria for full approval. So this all came out yesterday. And as I noted a moment ago, the Pfizer vaccine remains available under the emergency use authorization for individuals who are 12 through 15. And there's also now the possibility of the administration of this third dose in certain immune compromised individuals, something we'll talk about here. Not long ago, FDA and the US CDC officially now authorized and recommended a third dose of mRNA vaccine for individuals who are moderately or severely immune compromised. The list of the potential medical diagnoses that may qualify someone as being severely or moderately immune compromised is listed here. But it's things such as being actively treated for cancer, having had an organ transplant and being actively immune suppressed, or a stem cell transplant, having advanced or untreated HIV, or other conditions that would be associated with severe immune compromise. For those individuals, a third dose of mRNA vaccine is now recommended. Although there should be an attempt to match the third dose with the prior first two doses in terms of manufacture, it is not essential to do so and should not be a bar toward administering that third dose. The recommendation stands to give that third dose 28 days after the second dose. And as I mentioned, there should be an attempt to try to match it with the primary series, but not necessary to do so at the expense of not administering the third dose. 3 is the max. We're not recommending you go beyond 3 in terms of additional doses. And this does not yet apply to individuals who have received the J&J vaccine, mainly because there is not the sufficiency of data on which to form a recommendation. Now, there is another discussion that we'll have in just a minute around boosters, but I want to stop here right now and take any immediate questions either around now the full approval of the Pfizer vaccine or the additional dose recommendation for the moderately or severely immune compromised. Any immediate questions we can attempt to answer there?
And folks should feel free to use the chat, or you can unmute and ask. So I'm seeing one here. Isn't the third dose supposed to be 8 weeks, not 28 days?
No, the recommendation for the third dose is 28 days after completion of the primary series. There may be the recommendation for a booster is 8 months after completion of the primary series. So let me introduce a terminology that is relatively new to me, and so it was helpful for me to have a sense of this when the US CDC discussed it. They've introduced a distinction between an additional dose and a booster. An additional dose is effectively a continuation of the primary series. It's defined as a situation where the additional dose is given in somebody for whom the immune response to the primary 2 doses was not sufficient to confer protection. So there was an insufficient response. That is distinct from a booster, which we're going to talk about in a second. The definition of a booster being a third dose that is given to improve an immune response that was already mounted. So right now, when we talk about the immune compromised, we're talking about an additional dose on the theory that there was an insufficient immune response to the primary series.
I'll just add, so I did include hyperlinks, and we do typically post the slides and the recording to the provider portal of the Maine CDC immunization program website, and I'll put the link in there. So unless there's any concerns, I'll plan to post these as well. But the links go right to the CDC. So this information comes right off the US CDC website if anybody wants to read further. I'm also seeing is asplenia considered an indication for a third dose?
I believe so, but let me get Dr. Sears's consult on that.
Well, I hate to disagree in
Yeah.
public.
Okay, no, great. Good. I am not a
so-
clinician, so Dr.
Yeah.
Sears's view should trump mine every single day of the week.
Well,
on this.
you know, I think that the challenge with all of this is that the list is not finite of what is considered to be immunocompromising conditions. And it really has to do with each individual. But asplenia, really, the biggest immune deficit is responding to encapsulated vaccines and encapsulated organisms, so pneumococci and things like that. So I've not seen it listed overall, but I think this will probably expand as the CDC looks at this again, probably in another round.
I'll just tag on to that to say, I think a lot of people are also asking, well, older adults, we know that they don't mount as good an immune response, and people with other chronic diseases like diabetes. So I would just point out and disagree, Dr. Shaw, Dr. Sears, but those things are not on that list right now. This is for moderately to severely immunocompromised, and we really ought not be taking liberties with what is authorized right now.
Agreed.
Anybody want to disagree?
No, I will retract my statements again. I am not a clinician, so that is the reasoned expertise of two actual doctors should trump anything that I say. I want to pick up one or two other questions because this is a topic that is very much on everyone's mind. One came in around whether boosting with a different product is thought to be an attempt to expose someone to different antigens. There is at least one relatively small study from Spain, I believe, which did examine the mix and match approach and found a strong immune response to those. There's also been a strong immune response documented with continuation of the same primary series. I think it's too early to know whether the differential antigen presentation from slightly different mRNA vaccines would definitively improve the immune response. There's an early indication that it might, but I'd say it's too early to say for sure based on one study. But Stephen, what's your take on that?
Would agree. I think that there's some other data that has not yet seen really this really just preprint information from England, because England used a strategy in which they gave a lot of 1 doses and then came back and gave the second doses with perhaps a different preparation. But for now, I think try to match the vaccine to the one that the individual had is really the best strategy. I think all these questions may get answered more in the future as we get more experience.
Very good. We're going to dive back into the slides because this conversation is very tightly linked to the conversation around boosters. Again, when we were talking a second ago, we were focused on additional doses for the moderately or severely immune compromised, and that's the 28-day after the second dose. But the news of late has been around boosters. This would be a third dose, at least right now for the mRNA vaccines, for the general population, starting on or around September 20th of this year. The scientific basis for this is based on different lines of evidence, some of which was published in the CDC's journal, the Morbidity and Mortality Weekly Report, from 3 papers that they published about a week ago. Some of it is also drawn from some early data from Israel, as well as a preprint from our colleagues at the Mayo Clinic, each of which looked at different metrics, be it hospitalization, severe illness, or even infection in the case of the Mayo Clinic study. And each of them found varying degrees of waning immunity. In one situation, very little when it came to severe disease, but early indications, potential indications of waning immunity from some of the other papers now 8 months out after individuals have received their first series of mRNA vaccine. That was the basis for the federal government's recommendation to offer a third shot for those who have completed their mRNA primary series 8 months afterward. Now, there's still more to come. For example, full FDA authorization for this third dose, this booster, as well as the US CDC's advisory committee officially endorsing this strategy. The US CDC's advisory committee is meeting next Monday and Tuesday to review all the evidence and put forth more precise and granular clinical recommendations for providers on how to implement this booster dose approach. This is, again, somewhat in contrast to the additional dose. The booster dose will be broadly applicable to the entire population. And given the 8-month recommendation after the second dose, there's a bit of path dependence. That is to say, most states, including Maine, will follow the same approach that we followed in the first round, with healthcare providers probably first in line for their boosters, then followed by individuals who live in congregate care settings, moving down the line, so on and so forth, in that 8-month fashion after completion of their primary series. This will be something where there will be a lot more details. Tanya's team has already started working through the logistics of how we're going to make this happen on the ground. There will be much more discussion about that. We'll have much more to say. But today, I wanted to just pause again and take any questions around the booster piece.
There's one new question in the chat. You see this, Nirav, how is waning immunity measured? Is it based on immunized individuals?
So waning immunity, or immunity in general, is measured by things like levels of neutralizing antibodies and the titers there, as well as B cell and T cell response. But in these situations, and the papers that form the basis of these responses, this policy recommendation, those were based on calculations of vaccine efficacy, which is a slightly different calculation. Vaccine efficacy is a relative risk calculation that measures the likelihood of getting infected in two groups, the vaccinated and the unvaccinated. And that was the basis on which this policy recommendation was made. What these set of papers found was that based on what your benchmark was, hospitalization, severe illness, infection, there were early signs of evidence of waning immunity based on vaccine efficacy in some of those lower markers like infection, which could foretell waning immunity for things like hospitalization. Question here about what's to stop patients from taking this information and just going to a pharmacy to get another third dose or a booster now. The bottom line is nothing. We don't recommend that patients do that for a number of reasons, but not long ago, about 2 weeks ago, the US CDC put out numbers indicating that quite a few Americans across the country had already done so. Again, we don't recommend doing that for a number of reasons. We think that this is best done in a methodical fashion, so those who are truly at the 8-month mark can be in line to get their doses, so on and so forth. But in practical terms, especially now with the full approval of the vaccine, there's nothing that can be done, no steps that we're taking to stop folks from doing so, other than not recommending that they do.
And I think, to the extent that we've got clinicians on the call here, we would certainly encourage clinicians and primary care clinicians to encourage patients to hold off. That's not what's been authorized right now. I know the pharmacies have different procedures. Some want a note from the clinician, some have a self-attestation form, but I think our role is to inform them of the facts right now and what the recommendations are and to encourage them to wait.
Agreed.
I think the one other thing I'd add to that is it is not recommended to get antibody titers after vaccination as a way to make these decisions. It really should be made on the first cut on those people moderately to severely immunocompromised. And assuming everything goes through the ACIP and FDA, then there'll be guidance specifically on the populations to give the booster doses to.
Also, this question, if a patient does manage to get a third dose before it's recommended, do we need to report that anywhere?
Tanya, could we go to Tanya to talk about the reporting and the dashboard and all such things and what we've got in the works there?
Sure. So any dose that you receive from the Maine immunization program, which is all doses of COVID vaccine, must be reported through our impact registry. This is either done with an exchange with your EMR or a hand key directly into the immunization registry. So any dose that you receive for COVID-19 vaccine must be reported to impact. In that aspect, we are working with our vendor to also display that data onto the Maine dashboard. We're hoping to have these updates in place and available for the public viewing by September 20th. So all doses, regardless if it's an additional dose or if it's a booster dose, a first dose or second dose, all must be reported.
Though to be clear, Tanya, I think for this question is, if a clinician learns that their patient got their third shot somewhere, they don't have to report it because presumably whoever gave the person the shot had to report it in impact. There's no calling them out.
Correct.
Or reporting them
Correct.
negatively somewhere.
I misunderstood the question. So
well, I'm not certain, but I think that's
yeah.
Yeah.
Yeah. So the person who's administering that vaccine has a requirement to report. The minimum is 24 hours after administration. So all data of the administration site must report that into impact.
Great. I don't see any other questions right now, Aaron.
All right, we're going to go back to the slides. Tanya, if you could hold tight, because I'm going to come back to you in just a minute on some tactical questions. But before we get to the tactics, we're just going to project into the future a little bit, which is always dangerous in a pandemic. But what's on the horizon with respect to COVID-19 vaccines? Well, in general, we can start to see the same pattern with the Moderna vaccine as we've started to see with the Pfizer vaccine. Moderna itself has filed for full FDA approval for their vaccines for the 12 and over category, and that process is underway. It's on FDA's time, their time schedule as to when or if they grant that full approval, although we suspect they will. But the latest suggestion is that it could be anywhere from 4 to 6 weeks away. The other regulatory milestone that's on the horizon is the emergency use authorization for both the Pfizer and then later on the Moderna vaccine for younger children, those in the 5 to 11 category. And similarly, the Pfizer news will start coming out first, then probably followed by the Moderna news. And the latest that I've been told is that the FDA intends to do the authorization for this age category for the Pfizer vaccine in largely 2 tranches. First, sort of the 5 through 11, the 5 through 11 group, as noted here, over the next couple of months, and then followed by the 2 through 4 group, perhaps in the beginning of next year. So hopefully by the end of this year, maybe even a touch sooner, we might have news on the Pfizer front for 5 to 11, followed maybe some weeks thereafter by the Moderna piece. I want to shift, or let me just end this portion of the discussion with one major ask, and that is, as we think about boosters, additional doses, and now all of this being in the face of the Pfizer vaccine being fully approved, I'd like to take a second to make a personal plea, particularly for primary care offices out there. You're a primary care provider, but really any type of office-based provider, primary care or not, and you are not yet offering COVID-19 vaccines in your office, we'd like to work with you to make that happen. This is a top priority, and as we've known throughout the pandemic and as a lot of survey data have underscored, for the hesitant or the outright opposed to vaccines, the only people that they will listen to that have a chance of getting them on board with vaccines are their primary care doctors. That's the only group out there that will make inroads with them. Now with the vaccine, at least one of them being fully approved, one of the arguments that we've heard has at least been removed. And as we think about planning for boosters, having as many sites as possible, nodes as possible within the state is critical. So I would like to make an ask, if you're an office-based provider and you're not yet offering COVID vaccines, we'd like to work with you to make that happen. I'm going to turn really quickly now to some mechanics around ordering vaccines. And Tanya, if you don't mind, I'm going to just turn all of this over to you because you are the expert here, and then we'll pause and take questions.
Thank you, Nora. So as of right now, ordering through Impact is currently turned on for Pfizer and Moderna vaccine. You can see the minimum and the maximum doses that you can order here. If we feel that we're able to accomplish your request through a vaccine transfer, we will work with other providers in the area that you're in, or work through our Public Health Emergency Preparedness Depot and transfer you vaccine directly within our state lines. If we do not have the amount of vaccine that you're requesting, we will then process that order through the federal CDC. And this currently right now is for Pfizer and Moderna. J&J is a different topic right now. J&J, we are working on procuring additional vaccine to come into the state. We do know that we do have a backload of orders right now with providers who are seeking J&J vaccine. We are working through trying to accommodate those order requests. We'll hopefully have some positive news by the end of this week, beginning of next week for those orders. You can also see on the screen that there is an email address. The email address on here, if you would like to receive vaccine in less than those minimum shipping sizes. So if you want to receive just one vial of J&J or one vial of Moderna or one vial of Pfizer, we're also able to accommodate those requests. So we ask that you email us, make that request, let us know the COVID PIN number that you have, your provider location, and a contact name. So we're doing our best to accommodate any size of vaccine that your facility would like to have. And this goes moving forward with making that ask of routine provider offices and pediatric provider offices to accommodate smaller packaging sizes, because we know that you have a vested interest in making sure that you are reducing any wastage of vaccine. So making a plea that order the vaccine that you need for Pfizer and Moderna will accommodate those transfers. J&J, we're on back order right now. We are working through getting that process down pat so that we can have vaccine in the state and hopefully be able to meet what your needs are at some point of next week.
Great, and there are a couple of questions related to ordering there. Back a minute ago, are all pharmacy administered doses? So at the commercial pharmacies, are they getting into Impact? There seemed to be a disconnect on this earlier in the season. Any info on that, Tanya?
Yeah, they are coming all into Impact. They are delayed. I believe it's up to 72 hours. They are coming in through a different process. But all pharmacies, retail pharmacies, and even independent pharmacies that are vaccinating, that data is coming into Impact.
Great. And then about dosing, just to clarify, is the dose of the vaccine the same for the booster as well as for the third dose shots? Yes.
Yes.
Okay. Any other?
Yeah, other questions on sort of the tactical piece around ordering, getting stocked up. There will undoubtedly, with the authorization of Pfizer, there will probably be more demand for Pfizer now. That's a great thing. Tanya and I discussed this yesterday. We have ample supplies of Pfizer in the state. So we have the vaccine. J&J is a bit of a challenge right now, but thanks to Tanya's diligence and not leaving any stone unturned, we found some J&J in another jurisdiction. And we're actually sending a deployment team to go pick it up. So hopefully we'll have a bit more, but questions on the ordering and the tactical pieces.
Not seeing anything else.
Okay, all right, onward. So let's talk a little bit about the Delta variant. The Delta variant is the wrench that has been thrown in the spanner that has really kind of changed the trajectory of where we are in the United States and certainly in Maine. As you can see here, just 3 months ago in Maine, the Delta variant accounted for fewer than 1% of the samples that we were sequencing. It is now well over 90% of all cases in the United States and about 100% of all of the cases that we are sequencing in the state of Maine. What we know about the Delta variant is that its R value or its reproductive rate is much higher than the previous variants that we've encountered. It also has a shorter incubation period, all of which means that it is far more contagious. It is able to achieve that higher degree of contagiousness probably because it replicates so much more quickly and so much more earlier than prior strains, also leading to a higher viral load and thus lower CT values. As a result of all of this, there is a higher risk of acquisition of the Delta variant, particularly among unvaccinated individuals. There are open clinical questions about whether the disease that results from the Delta variant is more virulent than with prior strains, and thus whether hospitalization rates and fatality rates are higher. Right now, the data they don't definitively demonstrate a higher degree of virulence or fatality, although it can't be ruled out. There are also questions about the impact of the Delta variant on kids. One finding in Maine, as well as nationwide, has been that the rates of new cases, the incidence of COVID-19 in kids and in adults is effectively the same in the Delta variant era, whereas previously incidence in adults was much higher in kids. Now, there are some complicating factors there because you have to adjust for vaccination rates, but what we can say now is that kids are at least getting COVID at similar rates as adults are. That all leads to the understandable series of questions around what we know about efficacy of the 3 vaccines around variants. The bottom line is that all the clinical data we have still suggests that all 3 vaccines remain highly effective at preventing serious COVID-19 infection, even in light of the variants. But consistent with what I mentioned a moment ago, there are some early pieces of data that are starting to suggest lower vaccine efficacy, particularly around more severe markers like ventilation rates and hospitalization rates. That being said, the bottom line remains the same. The 3 vaccines we have, even the J&J vaccine, where I know there have been some questions, all 3 continue to show sustained high levels of protection against severe COVID-19 infections, particularly those that require hospitalizations. So again, I'm gonna pause there, see if there's any questions around Delta in particular. If not, I'll jump to breakthroughs right next. Question about the clinical risk of the Delta variant to children aged 1 to 5. Dr. Sears, Dr. Letourneau, I'll let you tackle that one.
I think if I understand the question, what was it? Am I echoing? Okay.
Nope.
If I understand the question, I think the question really is what is it as infectious for 1 to 5-year-olds as it is for other individuals? And it does appear to be. I think the unanswered question, as Dr. Shaw said, is it more serious? Is there more severe disease? Probably it doesn't appear to, but it clearly appears to spread rapidly through the entire population, including the 1 to 5s.
Well, the next question is around transmission of the Delta variant among the vaccinated, which we're going to just go to right now. So let us dive into a quick discussion around breakthrough cases. So on breakthroughs, which certainly have been a concern, something that's captured a lot of the public's imagination, something we take a lot of effort in making sure we're tracking. Definitely something to think through, but important to start that discussion by recognizing that with vaccine efficacy in the 90% range, it is entirely predictable and predicted that there would be breakthrough infections after vaccination. There is no vaccine that has ever been created. There's no medical intervention that's been created that's 100% at anything. So the breakthrough cases that we are seeing are in line with what mathematical predictions would have suggested. The bottom line, though, remains most vaccinated individuals do not experience a breakthrough case. They still remain quite uncommon. And even when they do have breakthrough cases, their symptomology is mild or completely asymptomatic. Indeed, many of the breakthrough cases that we identify are among individuals who we find who are participating in routine laboratory surveillance. For example, healthcare workers because of their role in the workplace. Vaccines remain incredibly effective. And what we tend to see right now is that among hospitalizations as well as deaths, it still remains the unvaccinated fraction that are accounting for an outsized number of hospitalizations and deaths after COVID-19. The last thing I'll mention is a lot of hand-wringing around increasing numbers of breakthrough cases. All I will say there is that as the number of vaccinated people increases, the number of breakthrough cases are going to increase. What matters is whether the rate of breakthrough cases is increasing. And thus far, although it has gone up a little bit in the past month, probably as a result of Delta, it has not skyrocketed. Numerically, it's gone up just because there are more vaccinated people, but the rate still remains really low. So I'm going to pause there and kind of that's sort of the clinical and scientific portion of the presentation. Any questions around any of that?
Nirav, one other question that came to me is there any change in the requirement for the 15-minute waiting after administration of the vaccine following the full FDA approval for Pfizer? The question wasn't that 15-minute part of the EUA versus is it still part of the approval?
I don't know the answer. I'm going to check on it really quickly to make sure I don't give out wrong information. I will check the FDA approved label. Everything I have been briefed on tells me that 15 minutes still exists, but I want to be 100%. So I'm going to check the label really quickly just to shore that answer up. I don't believe they've changed that. I think that would have been pretty big news, but I'll check just to make sure. And while I am checking, let me see if there's any other questions on that.
I'm not seeing any others.
All right, well, while I am checking on that, Bill, could I turn things over to you to talk about the vaccination and healthcare worker rule? Sorry to spring that on you.
Sure. Thank you. So as many of you know, on August 12th, there was an announcement about the mandatory vaccination for healthcare providers. The emergency rule is in place now. It does require that employees in designated healthcare facilities be immunized by October 1st. And the facilities that this applies to are listed in the emergency rule. There has been some confusion around home health agencies in particular. And just to provide clarification, and this is addressed in the FAQs that are posted on the website, the rule applies to the licensed entity, and for hospitals, it would be the licensed hospital and any outpatient or physician practice that is listed as part of that hospital license, operating under that hospital license and or billing under the hospital license or the hospital's Medicare CCN number. For home health agencies, it's any and all employees who are employees of the home health agency that is licensed. So there are some home health agencies, for example, that also operate a licensed behavioral health. And the rule as written applies to the home health only, not the behavioral health licensed entity. And that is also clarified under the FAQ. The emergency rule is available so that people can go on and view it. It is in place for 90 days. And I do know that there will be a posting for the full rule that will go through the formal rulemaking process and be opened up for public comments. I don't know if you want to go to the next slide. The only other thing that I would add to this is, and this is the matrix that is out, or the table that is on the FAQs that clarifies which facilities are impacted and which ones are not. And the only other thing that I would add at this point is that there was, President Biden did declare that the federal HHS will be imposing a requirement as a condition of payment.
If you keep going, there's another slide on that. Just flip through.
Okay.
One or two more. There we go.
There it is. So President Biden announced that the federal government will be requiring all nursing home staff to be fully vaccinated as a condition of payment. CMS is writing the interim rule now. The expectation is that this will come out in September, and the requirement will be in place really upon publishing of the rule. And we have yet to get guidance from CMS on the enforcement aspect of this, but my guess is that they will use the current process where facilities are reporting in through the NHSN, their vaccination data, and then the state agencies that are contracted with CMS will be going out and doing audits as directed by CMS for compliance. So a lot more will be coming out on the federal CMS requirement probably in September as the interim rule comes out.
Excellent.
Eric, if you want to maybe just screen share one more time, I just want to highlight the FAQs on these rules, because that really is the definitive source of information. So if you just go back, I think
100%. There we go.
There we go. Right. So if for questions, that is your best source of information on the governor's website, and it's got a whole drop down. That's only a little bit of the screen share that have many different categories and lots of info there. Thanks.
And we'll, as Dr. Letourneau mentioned, we'll have the slides online. You'll be able to click on the links to access a lot of the source materials for this. Before we take questions on the healthcare worker rule, just to follow up to the previous question, glad I checked on that. On the 15-minute observation period for the Pfizer vaccine, the FDA-approved labeling does note that syncope may occur in association with the administration of the vaccine. And so providers should have procedures in place to avoid injury from fainting, like observation. They interestingly don't specify a 15-minute period, but we would continue to recommend a 15-minute observation period. So with that, questions on anything at this point?
So there's one in here about the new rule. So is it correct that FQHCs or providers in FQHCs are exempt from the mandate? Are there formal efforts of the state to encourage FQHCs to follow the mandate so they can present a united front? Bill.
Sure. Oh, or Bill. Yeah, Bill, go
Sarah.
for it.
So I would refer to the table in the FAQs. Now, federally qualified health centers are not licensed by the state. They are operated and approved federally. So under the current emergency rule, no, they are not. They are not listed as subject to the mandatory vaccine. There may be some FQHCs that actually there would not be any operating under the hospital license because they are separately certified. So no.
And if I could just underscore that, because we're getting a lot of questions about this. It's not that they're exempt, it's that they are not included in the list of designated healthcare facilities that are licensed by the state. This really goes back to an existing rule. It's really just a change to an existing rule to add COVID vaccine. So nobody exempted them. It's just that they were not on the list to start with. So I put the link to where we post the recordings, and I'm going to put the link to the FAQ here shortly. So here's another one. I'm hearing that healthcare companies whose parent office is in a separate state don't have to be vaccinated even if working in Maine. And also, what about travel? That would include travelers. What about traveler healthcare workers? Bill or Sarah?
I'm gonna defer some of this and we'll follow up on it. As far as the traveler, if the traveler is working in a facility in Maine, then yes, they are subject to the mandated vaccine. If it's a facility that's listed under the mandated vaccine, such as a nursing home.
And I was just going to add that the contracted employees are covered under the rule, so that would go to Bill's answer for the traveling nurses, workers. And then for new hires, you have to be fully vaccinated by October 1st before you can enter the workplace.
And then can people with medical exemptions work in the building?
Yes, that's clearly in the rule. That wasn't changed. If you have a medical exemption, you can be in the facility. That's part of the rule. With accommodations, obviously, to mitigate transmission.
And then for new hires in nursing homes after October 1st, do we have to keep them out of work until deemed fully vaccinated, or can they work as long as they're in the process of getting their vaccine?
Must be fully vaccinated to be in the facility after October 1st.
Which is 2 weeks after the last vaccine, to be clear. Okay, and just to note, I put a link to the FAQ, but my clipboard, I copied the wrong one before, so I put it again. So use that second one if you're trying to get to the FAQ, sorry.
And one note on the medical exemption piece, I think it's important to note that, for example, in the FDA-approved labeling for the Pfizer vaccine, the only contraindication to the Pfizer vaccine, at least, is in an individual who had a known history, not a theoretical history, but a known history of a severe allergic reaction to any component of the vaccine itself. So it's a pretty narrow, very, very narrow series of individuals who may have a qualifying medical exemption.
And so really important point to call out for, again, the clinicians on the call, because the rule only allows medical exemptions, which people would go back to their own primary care or other clinician, right? So really important to be up to date with what the actual exemptions are from the CDC, which, as Nira said, are pretty limited. People have also asked, well, could they document their immunity with antibody levels? But as Dr. Sears said earlier, that is not recommended right now. There's no definition of immunity as witnessed by antibody levels. So we've got a couple of other ones here. Will compliance with a booster or third dose be included in the mandate?
We'll add that question in a response to the FAQs. That's not currently there. And we are taking on new questions and adding responses, updating the FAQs as we go. So we'll take that one and add it to the list.
Great. And also, Nirav, I'm not sure, I know I had different versions, but there was a slide just after the FAQ slide that talks about, there's another webinar this Friday, particularly focused on some of these issues about the rule. I can, you know what, I'll link to register. So folks are asked to register. I think it's right after this one. There we go. But I'll put that link as well. So it's this Friday at 11 o'clock. It will be focused fully on the rule. So it'd be another opportunity if folks want to join or pass this along to your colleagues. And I'll put a link in chat right now as well. What else here? Save the questions, yes.
I have a comment.
Yeah.
I have been a provider for 38 years, and I have Lyme myself, and I have dealt with Lyme for decades. And I am very concerned about how the state of Maine is handling this issue, knowing that Lyme patients are immunocompromised. They do not produce antibodies. And then all of these people that have died from COVID and Lyme that have died not from the diseases themselves, but from the inflammation that they're causing. And the inflammation is easily measured by a simple, inexpensive test, the same as with Lyme disease that most of the primary care providers know nothing about because it's not a traditional or conventional blood test, but it will show a measure of methyl peroxidase, which is inflammation. And those people that have Lyme that I've seen way before COVID, and then when North Korea and France were finding people dying of strokes and heart attacks, it was the same thing that I was finding with Lyme disease. And their MPOs are normally, it should be less than 600, and they're in the thousands. And these people that are dying and the young people that are dying from heart attacks and strokes, it's unbelievable that Maine is not doing something which they could be doing with New Hampshire, and doing a simple test that will show that they have Lyme disease and this measure of inflammation. That is what is killing them, not the virus. And so that these people that are getting the immunizations that is causing an increase in the immune response, and they're already confused immune system, which is what is causing the death. And this mandatory vaccinations without finding any kind of measurements for underlying risk is very disturbing. And I, as a healthcare provider, having mandatory vaccinations, you're basically killing people by forcing them to having an immunization that they should not be having. I should not have one. My immune system I have had to go out of state to get care. And I will be moving to New Hampshire, most likely, if Maine continues as it's going. And it's hugely disturbing, especially when you involve the kids, because the kids have a very good immune system. And I have found, I have all kinds of evidence. And if we did a simple study instead of this sending out stipends for $1,500, a $200 test would show these people. I have a number of patients that have this elevated MPO, and they will die of a heart attack and stroke. I would have died had I not gotten treatment because I had stroke-like symptoms, and my PCP and supposedly Lyme literate provider denied it. So
Sandy, I'm very sorry to hear about this sequence, but I just want to give time. We're getting close to the end of the hour, so I don't know. I am certainly not at all.
Well, I hope that Dr. Shaw and the state of Maine will look into this simple test that's not traditionally known, but it will show viruses, parasites, and the actual organisms that's causing the virus and the inflammation.
Let's give a chance for them to respond.
Yep. No, thank you for sharing that. I know it sounds like you had quite the travail with this. So thank you for sharing that, and we'll look into it further. I can't make any promises of where we'll land, but we certainly will look into it further. I also want to make sure in the 5 minutes we've got, we give a chance for some other providers to get some questions answered. But thank you for chiming in.
And besides prevention, besides immunizations, what are you asking people to do for prevention and treatment?
I'll just say here really quickly, we are continuing to recommend masking, other non-pharmaceutical interventions, as well as working with providers to ensure that other FDA authorized therapies are freely and widely available. But I want to turn to some other providers here to make sure we get some other perspectives.
Just on the maybe a related sort of inflammation and allergy question, I noted Dr. Penoyer, who's immunologist allergist, noted that on this question of whether people have a contraindication and allergy, the vaccine, those with a history of severe allergic reaction should be encouraged to consult an allergist for testing and discussion of safe receipt of the second dose, or potentially if they have questions about even getting a first dose. So thank you, Peggy, for that.
Mhm.
And then there was also another comment about encouraging FQHCs to follow the mandate. I would say, Amy, we certainly would encourage FQHCs and would certainly encourage the association to encourage their members to do that. Again, that the rule just does not apply to them right now. Also, there could be comments in support of that in the formal rule that will follow the emergency rule. So those would be probably the best mechanisms for that. There's a question back to the rule. How are others addressing vendors who enter the building? So Bill, I think that's a you question again.
So that's not addressed in the current rule, but it is addressed in the CMS requirements for visitation, QSO 2039, which does require that all facilities have a screening process for individuals that are entering their facilities.
Okay, and then one more clinical question. Is a booster indicated for those who had natural immunity, presumably from having had COVID infection and received at least one COVID vaccine?
Let me just make sure I'm reading that correctly. Stephen, if you want to weigh in here, but okay, so had natural immunity and received one COVID vaccine. Well, so if someone had natural immunity, we do recommend that they, if they previously had COVID, they get vaccinated nonetheless. And thus the booster would still be recommended 8 months after completion of that primary series, irrespective of their pre-existing COVID status. That's how I read the CDC's recommendations. But Dr. Sears, what's your take?
Same as yours. And, you know, I think that there's a lot of small studies that suggest the people who have had natural COVID who then get vaccinated have significant antibody responses. But again, those are, it doesn't really change the recommendation that people should get vaccinated, because we know that people with natural immunity also can get reinfected, and the period of risk starts at about 90 days.
And I think it's fair to say in conversations with their patients, right, for clinicians, that we don't know that people who have had COVID infection with natural immunity, the response can vary widely, right? That's why the predictability of the response with the vaccine is higher and more robust. So people who say they've had previous COVID should not, it's not a reason not to get the vaccine. Fair to say?
It is, and I'm going to pop in a paper from our colleagues in Kentucky that just published a paper in the MMWR very much on this topic about 2 weeks ago. I'll throw a link to that in the chat right now.
Great, thank you. All right, and with that, we are at the end of an hour. So that flew by. Thank you all. Thanks so much, Dr. Shaw. Dr.
1 second.
Sears.
Sorry, I want to put this in the chat before.
Yeah, I'm
everyone
not. I'm just saying thanks to everybody. Yeah, I'm filling the air here.
Okay,
so there
good.
it is. Thank you very much. And just a reminder for clinicians that we typically we've been holding these sessions once a month on the first Tuesday of the month at 7:30. Typically they're 30 minutes. So we will be back to that schedule on Tuesday, September 7, unless there are more developments that prompt an extra session. But thanks so much. Thanks to all our professional association colleagues who helped spread the word on this, and everybody for joining. As mentioned, we will post the recording and the slides within a couple of days to that MIP website that I put earlier, or feel free to always email me if you can't find it. Sometimes if you don't have the link, it can be a little bit hard to find. So just lisa.letourneau@maine.gov, and happy to send that to you. All right, thanks everybody. We'll finish up.
Thank you all.